You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is August 11th, 2023. Our topic today is Basics of Skin Testing. Our presenter is Dr. Paul Dowling. He was a former Allergy and Immunology Program Director at Children's Mercy Hospital in Kansas City, Missouri. He is speaking to us today from Las Vegas, Nevada.
Welcome everybody to Conferences Online in Allergy. Today is August 11th, another steamy day in Kansas City. Today we're going to have two conferences or presentations, and both of them are going to be people that are either working or have worked for Children's Mercy in the past. And our first speaker is Dr. Paul Dowling. He was our program director for, I won't get the number right, but 30 years, 25 years or something long like that. I was the associate program director with him during that time. So Paul taught me a lot, was always a good mentor and a great peer to me. Paul is coming out of retirement today from Utah, and he is going to be talking about the basics of skin testing. So thank you, Paul, for being here.
It's a pleasure, and it's good to see some familiar faces. Today I'm going to talk about, as Chris said, the basics of skin testing. I don't have any disclosures because this is a rather dry topic. I have decided to enlist the help of my two dogs in this presentation. So you'll see how this works out. For a little dramatization, to give a little levity to this. I actually split my time between Las Vegas and Utah, and right now I'm in Las Vegas. So I'm going to introduce my dogs. So just like Gracie and Jake, for the incoming allergy fellows, you're experiencing this whole new environment. I threw this picture, and this is a picture for the fellows at Children's Mercy. This looks familiar because this is the conference room we use in the clinic. But for the new fellows, you're no longer pediatric or medicine residents. You're now in allergy. And so today I'm going to try to make it more comfortable for you in the world of allergy and to talk about skin testing. A couple of things you should remember is that skin testing and immunotherapy are the two most important things that distinguish our specialty from other specialties. So it's very important that you be an expert on skin testing and immunotherapy. So let's get on with this. From a historical perspective, the first skin testing was introduced in 1865 by Blackley. And he basically took some grass pollen, put it on some wet lint after he abraded the skin with a lancet and occluded it. And lo and behold, he got a cutaneous reaction with wheals and flares, and also found out that the more he abraded the skin, the increased chance that there was going to be a systemic reaction. In 1908, Mantoux developed the intracutaneous test, and then the first prick test was a number of years later by Lewis and Grant with some refinements. So what's the mechanism of skin testing? Why do we do this? Basically, it detects presence of specific allergen, IgE, on mast cells. And it also implies that the mast cells that we have on our skin are similar to those that are in our nose, our lungs, our eyes, our GI tract, and they would react similarly. An allergen is put in contact with cutaneous mast cells, and binding occurs to mast cells that are specific for that allergen. So again, if you have IgE mast cells and an allergen presents to that can cross-link, you'll have a resulting activation of the mast cells, and they release a whole variety of mediators. The ones that we're most familiar with is histamine for sure, but there's things like chymase and tryptase that are also there. Histamine is what's primarily responsible for the wheal, which is that edema. the bump that you see and the flare, which is the redness around the bump. And just as a reminder, especially for the fellows, because you may not have seen this and all of a sudden you might see it or some patient will call in later, there are things called late phase reactions that can occur 4 to 24 hours, sometimes up to 48 hours after testing. And basically, you'll have swelling of the deep tissue and redness, warmth, and maybe itching at sites where the skin test was initially negative. And this is a late phase reaction, and it doesn't predict symptoms on exposure. So it isn't that someone calls you up the next day and said, I have this big bump on my back where you put the dog allergen, and somehow that's an indication now you have to put them on dog immunotherapy or something. So it doesn't predict symptoms on exposure, the late reactions. Just to keep that in mind, because occasionally you'll see this or a patient will call in with that. For any of the fellows that are in the audience, question number 1, can you name any indications for skin testing? Anybody want to brave that? Don't be shy.
For like aeroallergens versus like food testing, seeing it's yeah, I mean, kind of seeing if someone is allergic to it.
Okay, great. Anybody else have any others? Okay, let's go here. So again, it's to identify environmental exposures, environmental allergens, food allergies, drug allergies, stinging insect allergies, and things like latex. It can confirm a sensitization to a particular allergen. So if you have suspicion that you might be reacting to something, and also can help identify triggers for people that have allergic asthma or allergic rhinitis and conjunctivitis. There's also non-diagnostic purposes for skin testing. Skin testing is used in standardizing allergens that we use for immunotherapy and for testing. They're used for pharmacologic studies, they're used in immunotherapy studies, and they're used in epidemiologic studies. So again, things to keep in mind. Okay, I'm gonna press the fellows again for question 2. Can you name any advantages of skin testing over blood testing? Anybody?
I think a big one is like time of test. You get results like pretty quickly, whereas like a blood test, you have to kind of wait maybe a day or 2 or 3.
That's correct. That's a good answer. Anybody else have any other thoughts?
Potentially shows more clinical reactivity versus like compared to just sensitization, like on the blood test potentially.
Well, you're still going to have to look at the history for those two, but okay. Anything else? Okay. As was mentioned, they're quick and simple to perform, so you can do it and get a result within 15-20 minutes. They're highly sensitive. They're relatively inexpensive compared to blood testing. And you can do multiple allergens at a time. When you see someone in the clinic, you have a whole bag full of skin testing on many occasions. So again, you can get a lot done in a short period of time, and it's relatively painless, and the results are usually pretty good. They also correlate results with mucosal, nasal, and bronchial challenges as well. So disadvantages of skin testing, if they're performed improperly, they can lead to false negative and false positive results. So this stresses the importance of proper training of staff and periodic competency checks. The positive skin test doesn't necessarily mean someone's allergic or will have symptoms. It only indicates sensitizations, and that's one of the most important things you can learn from this lecture today, is that a skin test or even a blood test by itself only indicates sensitization. It doesn't indicate an allergy. So a lot of people have skin tests, they get some positives, and they just, oh, I'm allergic to 15 things. Well, no. If you have a history of something and you have a positive skin test to that, then that's a true allergy. The other thing with the disadvantage of skin testing is it can be hindered by drugs that may have been taken, such as antihistamines or tricyclic antidepressants or things of that nature. If someone's dermatographic, where they have, if you write on their skin or stroke their skin, they'll get like a hive or a wheal and flare there. They can react to just stroking the skin or just using the device on the skin. So they would have a positive saline, a significantly positive saline, just from the motion of just scratching the skin. So that makes it very difficult to interpret. And if there's a significant skin disorder, like severe eczema, or there's a couple other indications as well, sort of like someone has chronic urticaria or something like that, be difficult. And false positive skin tests may result in unnecessary elimination of food, drug, animals, etc. And false negative may miss a diagnosis and proper treatment. So again, it's really important that if you're doing skin testing, that the skin testing be done proficiently and adequately. So there's two types of immediate skin tests. There's the prick or puncture, and then there's the intradermal. And the fellows are probably more familiar with the prick. However, we do use intradermal in a number of occasions as well in allergy testing. So let's talk about safety. A lot of people don't think that skin testing, or especially prick skin testing, is something you have to really worry too much about. However, you will find at some point in your career that you will have someone who will be significantly sensitive and may have an anaphylactic reaction or breakout in generalized hives from just doing a prick skin test. So it's possible. It's more likely to occur if you're doing intradermal skin testing, which you may be doing like with if you're testing for antibiotics, for example. So it's important that if you're in a clinic that you have emergency equipment readily available and are ready to handle any emergency, even though it's maybe quite rare. It's important you have that available. And it's especially to be careful with patients who have had recent allergic reactions, especially significant ones. You need to determine the potency and the stability allergen extracts used. Make sure that they haven't expired. Make sure you're using the right concentration for testing, such as like with histamine. There's two different histamines, one for prick skin testing, and there's a different histamine concentration for intradermal testing. So again, be sure the test concentrations are appropriate. Include a positive and negative control, which we usually use as saline and histamine. As mentioned in a couple of slides ago, histamine causes a wheal and flare, so we use that as our positive control. And then perform test on normal skin, as was mentioned. Check for dermatographism. Check for medicines used and the timing before testing. And record appropriate reactions, usually within 15 minutes of placing the skin test. And remember that the histamine peaks in 8 to 10 minutes. So if you have someone who you're not sure if they've been off of medicine long enough, you can put positive and negative controls on. In 8 minutes, you'll know if they're going to react to the histamine or not. And if they don't, you can abort the skin testing. If they do, then you can go ahead with it. So what do pricks and puncture skin tests tell us? They detect an IgE reaction, as we mentioned. The antigen is placed on the device or maybe a drop on the skin, and it's pricked or punctured with a variety of devices, results in a wheal and flare. And just to remember, the prick test is more specific. So for example, if someone had a test done and they were positive to let's say for to a weed, they'd be more likely to be specific to, let's say, ragweed, as opposed to just being a weed sort of thing. They correlate better with clinical allergy, and they're safer to do than the intradermal testing. This is a picture of a number of devices that are used for skin testing. There's also needles that are still used in some practices. And for the people at Children's Mercy, in the bottom row at the far right, there's a Dermapic, which I assume you're probably still using at Children's Mercy. But that's the device that I have the most experience with, having been at Children's Mercy for a number of years and using that. It's important to note that there is differences between these devices and how well they correlate, and so that's something we'll talk about in a minute here. So there's been a big effort to standardize skin testing because there are a number of different extracts that are used for testing and a variety of extract companies that are out there. And as you know or will know, a number of the allergens that you use on a regular basis are standardized. So it doesn't matter which extract company, they're basically the same concentration and potency. However, the majority of extracts are not standardized, and so they vary from company to company. And depending on what company you use for your testing can have some different results. There's also the different devices used for testing that can also have some differences in reactivity. It's important to note that people are a lot more mobile than they were 20 years ago. So it's not unheard of for someone to have skin testing done in Kansas City, and let's say dad or mom is in the military and they start immunotherapy, and 2 years later they get transferred to Kentucky, let's say. And so if they were transferred traditionally in the past, if they were going to go to an allergist in Kentucky and resume skin testing, the allergist would say, well, I can't read the skin test. They use different extracts. I can't make what the 1 + 2 + 3 + means on the skin testing, and I'm just going to start from scratch. So they would retest the patient and then restart immunotherapy for that patient. And so there's been a big effort to try to have things more standardized. So if someone moves from location to location, that if you have an idea how the skin tests were done, how they're measured, what the potency of the extracts were, what extracts were used, then you have a better chance of being able to replicate that or have something similar to that, and may be able to continue the immunotherapy or modify it a bit, that you wouldn't have to start over from scratch. So the college and the academy and the practice parameters for the Joint Task Force made a big effort to encourage standardization and make it easier for patients and allergists to understand skin testing. And skin test sheets should reflect the allergens used, the manufacturer, the controls, the criteria for positive reaction, grading system used, etc. So people can know what that means. Because in the past, and I'm sure Dr. Miller has seen this as well, you'll get skin testing sheets from some other allergists, and it has like 1 + 2 + 3 +. You have no idea what that means because there's no standardization, and there's no explanation of what 1 + is, how big that is, or whatever. This is a copy of the bottom of the skin test sheet that was used at Children's Mercy when I'm there. I'm not sure if it's changed much since then, but as you can see at the bottom, it has what's in the mixes for the different allergens. It has the controls and the concentration of histamine. It has that Greer extracts were used. It tells who applied it, who read it, the recording physician. It tells prick skin test are applied to the back using the Dermapick system, and are read at 15 to 20 minutes after application. Intradermals are applied to the arm using a TB syringe. All tests are expressed as millimeters of wheal over millimeters of flare, and a positive test is 3 millimeters of wheal or 5 millimeters of erythema, greater than your negative control. So that tells you a lot there. They're on the college and I believe the academy websites. They have templates for people to use and adapt to their own practices, so that they can provide all this information and again have more standardized skin testing sheets that can be sent from allergist to allergist. So that's just important to remember. This is an example of a very angry back after someone's had skin testing and is allergic to quite a few things. And you can see the number of positive reactions there. So let's talk about prick skin test technique. it's important that you do skin testing appropriately. You clean the back with alcohol. So you use little alcohol pads to clean the back. You place a drop of the allergen. It's usually 1 to 10 or 1 to 20 weight per volume. Sometimes you may use fresh, especially things like with food. Sometimes that may be an indication for doing that. And they're placed on the volar surface of the forearm or the back. You use one of the commercial devices, and you should use the same one consistently. So again, like at Children's Mercy, they use Dermapic. And these are dipped into a well, and they get a drop of the allergen on the tip of it. The prick skin test is best if you do it at a 45-degree angle, and you basically lift the skin there's like these little teeth on the end of the Dermapic, at least. You kind of lift it, and you'll hear a pop in the skin. You'll kind of feel that pop when you're doing it correctly. The test should be at least 2 centimeters apart to avoid overlap. And again, you use your positive and negative controls, check for drugs that may have been used so that they're not interfering. And again, once again, always check for dermatographism before testing. Common errors in prick skin testing. If the tests are too close together, you get overlapping reactions. You can get induction of bleeding that can lead to false positive results. And if you do a poor technique and you don't penetrate the skin, you can lead to false negatives, which is more common with these plastic devices, which a lot of people use. And it's important to realize also when you're putting on the skin test, especially if one of the nurses is doing it very quickly, often these allergens can run. And so it's very important that as you're getting the skin testing done, that you blot it. And so at Children's Mercy, the nurses would have the patient lay on their back, lay on their stomach. They would expose the back, and they do the skin test. And then they would take a open paper towel and basically just place it on top and let that excess stuff be blotted away, not wiped away, because you'll move the allergen to a different spot, but just blotted so it'll just be absorbed by the paper towel and it won't move. This was a study that was done, and I'm not going to go into it, but basically they looked at a number of different devices and saw there was a difference between what was considered a significantly different than your negative control. And the ones on the left are ones that if you use them, a 3 millimeter difference would be considered positive. The ones on the right would need more than 3 millimeters to greater than your negative control to be considered positive. So you can see, like the Duo tip, they recommend 3.5 millimeters greater than your negative control. But by kind of standard now, most people say at least 3 millimeters greater than your negative control. The other test that we do for skin testing is intradermal testing. Again, we don't do it as much, but this is an example of a picture of someone doing an intradermal and placing a bleb with a little bit of allergen in this syringe, the TB syringe. So in the intradermal skin test, you have a small volume, usually 0.02 to 0.05 ml, is injected intracutaneously to produce a superficial bleb. You only need enough to make the bleb. You don't need to have any extra, and you're more likely to get it to squirt out and spread all over if you try to put too much in. The intradermal skin test is more sensitive, so again, it's more likely to pick up if you're allergic to weeds in general than the prick skin test. But usually the significance is not very great for the most part for skin testing. When I started out as a fellow, we used to do prick skin testing, and if the prick skin tests were negative or barely positive, then those would be followed by all the same tests done intradermally. We don't do that anymore, and most places don't do that anymore, even though there are some places that still do a lot of intradermals. Is that there's studies that show that if your prick skin tests are negative, but you have, let's say, a positive sorry about that. someone's at the door and our dogs don't really like the sound of the doorbell. Anyways, if you have a positive intradermal alone by itself, the intradermals, studies have shown that the intradermal alone isn't very helpful. And if you were to basically put someone on immunotherapy because they only had a positive intradermal, you really don't get very much benefit from that. So we don't use that much anymore, the intradermals. However, they are still important in things like penicillin and other antibiotics testing and for some other biologics. The intradermal requires about 1,000-fold less concentrated extracts than those used in prick and puncture testing to achieve a similar response. You can't use glycerin as a diluent because it can cause a irritant reaction. So extracts that have glycerin with a diluent for intradermal testing, you'd have to get special extracts for intradermal testing that don't have glycerin because they can cause a false positive irritant reaction. And again, the concentration of histamine is different than the concentration used for a prick skin test. Always perform a prick skin test first if you're going to do prick and intradermal. If the prick skin test is significantly positive, there's no need to do the intradermal. And if you were to go ahead and do an intradermal, if you had a significantly positive prick skin test, you have a high degree of inducing anaphylaxis. So that's one of the things you should learn quickly is that if you're going to be doing an intradermal, always do them after the prick test and only if the prick test is negative or only mildly positive. Common errors for intradermal skin testing. If the sites are too close together, can cause a false positive. If the volume is injected is too much, you can again cause irritation of the skin and can cause trauma. The higher concentration of allergens can lead to false positives, so if you don't use the right concentration. Splash reactions, as I mentioned, is caused by air injection, and subcutaneous injection, if you go too deep, it can lead to false negative results. And too many skin tests placed at the same time with intradermals can induce a systemic reaction. So again, all these things to have caution with, especially when you're doing intradermal testing. Okay, a question for the fellows once again. Can you name any contraindications for doing skin testing?
If their asthma is like uncontrolled or flaring up when they're coming in.
Okay. Anything else?
Antihistamine used in the past 7 days that may skew your results.
Yeah.
Or the drugs.
A variety of drugs that can be important. So those are two important ones that were just mentioned. A lot of people, if someone's had a recent significant anaphylactic event, they'd be less likely to want to be doing skin testing, and I'll talk about some caveats to that. Taking medicines, as mentioned, that may interfere with treatment of anaphylaxis. Again, as was mentioned earlier, if someone has atopic dermatitis, bad eczema, if you can't find any, clean skin in a sense, it makes it more difficult. And patients with atopic dermatitis tend to have less reactive skin when you're actually testing. If someone's dermatographic, again, just stroking the skin with the device can cause a positive reaction, a false positive. Someone with chronic urticaria that may flare up at any time, their hives, especially if they're stressed, can again cause false reactions and mastocytosis. As mentioned, someone with poorly controlled asthma, history of severe reactions to even minute amount of allergens. I once had a patient who was highly allergic to cockroaches, had worked in a facility where there had been lots of cockroaches, and this affected her asthma. And she came in and we were doing testing because we thought we could start her on immunotherapy, and we just did the prick skin test, and she had a severe episode of anaphylaxis, had to be taken to the emergency room. So again, just keep these things in mind. If you have significant cardiovascular disease, especially for more elderly patients, people that are in frail health, and pregnant patients as well. So those are all things to keep in mind. There's been controversy about testing someone who's had recent anaphylaxis, let's say to a foods, let's say they reacted to peanuts or something, and or they thought they reacted to peanuts, and they were taken to the emergency room, and now they come to your office, a week or two later, and want to be tested. When I was a fellow that was concerned, and the only stuff that was ever published that I was aware of at that time was related to stinging insects, that if someone was stung, then they usually recommended you wait about 6 weeks after being stung, because basically if you had anaphylaxis with stinging insect, you basically released all these mediators, and they needed a chance to reform, and that you may have a falsely positive or falsely negative testing if you tested before 6 weeks, because these mediators hadn't all reformed. I never, when I was in my training in a number of years as an allergist, I never heard of not testing anybody shortly after an episode of anaphylaxis like to foods. The only time I'd ever seen that done was for stinging insects. And over the last 10 to 15 years, there's this kind of morphed into this thing that anybody that has anaphylaxis to any cause, you should maybe think of not doing testing for 4 to 6 weeks or something. When I was still at Children's Mercy, one of the fellows looked at some of our data, and we actually followed patients out, and found that a number of patients, especially when we were testing to foods, that they came in a week or two after being seen in the emergency room, they would have positive skin tests to these foods. There is some indication that the testing may be less positive than it might be, and that's still kind of open to debate. But I guess the bottom line is that you can do the testing, skin testing. If it's negative, you can always follow that up with a specific IgE blood test, and the blood test is less likely to be affected by recent anaphylaxis. And again, if again, the blood test could be done instead of the skin test if you really are concerned that the blood test may be falsely negative. But there is, and if it's positive, then you have your answer. You don't need to be worrying about retesting. So again, it's just something to consider, depending on how important it is to figure out what is the cause of someone's reaction. So anyways, just keep that in mind. The last question for the fellows, can you name any factors that can affect skin testing?
Humans, like itself, like just like who's who's doing the skin testing, like I feel like.
Okay, so the proficiency of the tester, I guess. Anything else?
I'd say like if they have a history of eczema, the skin testing they're more bound to be sensitive to other things or react to more pricks.
Yeah, actually, patients who have eczema, as I mentioned a little while ago, when you actually put controls on like histamine, they tend to be less reactive when you're actually doing the skin testing. So let's go through some of these things. There's a number of things that have been purported out there. The area of the body, the middle and upper back are more reactive. So the back is better than the forearm, that's better than the antecubital area, that's better than the wrist. There's some researchers that disagree. While I was at Children's Mercy, I was involved in a lot of clinical research studies, and there were a number of research studies where we did skin testing, where the clinical study itself had parameters where they actually told you where you had to do the skin testing, and even the timing of the skin testing, because there's also some thoughts about circadian rhythm to the testing. So if you were doing skin testing, you had to do it at during a certain period of time, every time they came in for like repeat skin testing. The age is also important. For infants younger than 3 months especially, they may not react to histamine at all. We also know that the wheel, which is what we look at when we have reactions, increases from infancy to adulthood, so it gets bigger as patients go through childhood and reach adulthood, and they also decline after age 50. So those are all things to keep in mind. There's no clear-cut difference with gender, race. For non-atopic blacks versus Caucasians, the non-atopic blacks have larger wheal responses to histamine. Pathologic conditions, as I mentioned, eczema diminishes the response to histamine. You may also see a diminished response if someone is suffering from chronic renal failure, and even in some cancer patients. And you also need to avoid testing around a skin lesion as well. And as mentioned, drugs are out there, especially antihistamines. One thing that people forget about is like tricyclic antihistamines that can be used for a variety of things, from migraine headaches to bedwetting and such. Those can have a significant antihistamine effect, and you need to be checking those medications. And this is just a list of some of the medications and the effect that they can have. Most important are the H1 and H2 antihistamines. So the first generation antihistamines usually will, most people will wait probably about 3 days or so if you were to use like diphenhydramine or something. And for the newer antihistamines that are once a day, usually they'll wait up to a week before doing skin testing. When I was a fellow, there was an antihistamine that was I think it was the first non-sedating antihistamine. If I recall, I think it was non-sedating, but it was called Hisbanol, and it actually stayed in your system for 3 months. So if you stopped it, you had to wait 3 months before you could do adequate testing. Again, just kind of keep that in mind with some of these drugs that can have an effect on skin testing. Even steroids being placed on the skin can have an effect. Okay, let's talk about grading of skin testing. I mentioned it a little while ago about people doing 1+, 2+, 3+, 4+. If you're at Children's Mercy, you know that they measured the wheel, the longest diameter of the wheel and the flare, and those are reported. And so you can look at the size of the reactions, not 1+, 2+, 3+, or whatever. Again, just a reminder, skin reactivity to histamine peaks at 8 minutes. The rest of the allergens usually will peak by 15 minutes. The prick skin test should be at least 3 millimeters greater than your negative control or your saline, and the flare 5 millimeters. Historically, again, a lot of people would choose the 0 to 4+ to correlate with grading and size. And I know that from where I trained that there were allergists that I trained with that basically didn't want to take the time to have a nurse measure the wheel and flare, and they would just go and look at the back and go, write this down, and they go 1+, 2+, 2+, 1+, 3+, whatever, and by just looking at the skin. And again, there's a lot of problems trying to interpret that for other allergists if they're moving on to someplace else. The Scandinavian Society of Allergology recommended skin test results be standardized in correlation to the size of histamine, and to calculate the mean diameter. Histamine was considered 3+, half that size was a 2+, double it was a 4+. So I think by convention, most people think of your histamine, you have a good histamine control, that being a 3+ reaction. And so if you're a 1+, 2+, 3+, 4+ person, you can kind of go from that. It used to be that if the reaction was significantly larger than the histamine, and or had pseudopods or satellite lesions, this was automatically considered a 4+. For fellows that don't know what I'm talking about, pseudopods, you can have patients that will have reactions, significant reactions, and they will get this little bleb off the side. Instead of being like a nice circle or oval, you'll get this little bleb off the side that reminds you of an amoeba from high school biology, and like a little pseudopod coming off it. That's not uncommon to see that in patients that have significant reactions to skin testing. The other thing that sometimes can happen, and it's more rare than pseudopods, you can get satellite lesions where off from where the skin test is, off to the side just a little bit, you can get these little small little wheels that are off to the side, tiny little ones that look like little islands off to the side, and those are considered satellites. So again, thinking about that. But again, the best method, and it's really not that time consuming, is to measure the longest diameter of the wheel and the flare, or the mean diameter, measuring the longest diameter and the diameter at 90 degrees to that for your wheel and flare, and recording those values on your skin test sheet. There was a study done by McCann and Ownby in which allergists were shown pictures of skin tests and asked them to grade them, and they showed greater variability, and concluded the most reliable method was to measure and record a reaction, then going off your eye and saying this is 1+, 2+, 3+, 4+, because the results were all over the place. I dug this out from a book from that was published in the 1960s to show all these different ways that people thought about interpreting skin tests, and they have this, like, it's the size of the nickel, is there pseudopods around it or not, and then it's like if the wheel is a 1.5 to 2 times, or 2 to 3 times, or greater than 3 times, or the pseudopods. And again, even if the controls aren't good, this last one was if the control is less than 2 millimeters, which isn't a good control to begin with, they were trying to make some kind of way of interpreting that. So again, the best thing is measuring the results, and reporting them by their size, not by 1+, 2+, 3+, 4+. So how do you interpret the skin test once you've got them finished? Positive reactions without clinical history indicate sensitization, not a true allergy. So again, if I can't stress this enough, having a positive skin test does not mean that you're allergic. If you have a positive skin test and you have a history that correlates with that allergen that was tested, then that's considered an allergy. So you also have false positive and negative skin tests you have to take into consideration. If you have, say someone had a reaction to, you think to peanut, and the skin testing came back and it was negative, you could follow that up with a blood test, if that's significantly positive, then you can say, yeah, you got a significant history and significant testing. There are on occasions patients that you may do skin testing and blood testing, the skin test and blood test, when you first do that, may be negative, but they have such a convincing history, and what they were exposed to was a limited allergen that you may tell them to avoid that, even if you can't prove it by skin test or blood test. But that's pretty rare. The other thing to remember is that the size of the skin test does not correlate with the severity of a possible reaction. A lot of people, when they see skin tests, especially parents, when they see skin tests done in the clinic, they'll see a big skin test reaction and then they'll go, oh my God, they're going to have anaphylaxis if I get exposed to, you know, cat or dog or something like that. No, the size of the test does not correlate with severity of a possible reaction. The only thing that it does, the larger the reaction on skin testing, or the larger the result on blood testing, is more likely to correlate that you're going to have a reaction of some sort. Could be just some itching, or it could be a full-blown anaphylaxis. Doesn't tell you about the severity, just means you're more likely to have a reaction if you're exposed to that allergen. Okay, the famous author Mark Twain once said, you're never wrong doing the right thing. So I'm going to change that. I'm going to modify that a bit and say you're never wrong doing it the right way. And so I'm a big believer in proficiency testing for skin testing. This should be something that be done in all clinics by anybody who may be doing skin testing. So that includes the nursing staff, as well as the fellows and the attendings, as far as I'm concerned. As with all laboratory tests, it's essential that quality standards be set to ensure accuracy of testing. And as you saw, there's a variety of different devices that are used, and there's drawbacks, and there's easy ways that people can have false positives and false negative reactions. And so again, it's very important that people have expertise in the device that you're using, and can be able to do the skin test appropriately, so you have appropriate results, and that you can rely on those, because you're making these life and death decisions in some cases about, are you going to remove an allergen, or are you going to treat somebody for something. Interoperative variation technique is problematic. It's important to have the sufficient consistency. And to assure consistency, it's important that anyone doing skin tests undergo evaluation of their technique. Different standards have been set, but the most lenient set is a coefficient of variance of less than 30% between your different skin tests. And I'll go through this here in a minute. One thing that I want to stress is that watching skin tests being performed and doing a number of skin tests is not sufficient. So, you know, for the new fellows especially, if it's slow in the clinic and the nurses are doing skin testing, ask them if you can watch, and then after you've watched him do a little bit, basically ask them if you can start trying to do some of the skin tests and help them out, because you're not going to get any experience unless you have hands-on experience. And it's important because you will likely at some point be going into the hospital and having to do skin testing during consults, say for drug testing or something in the hospital. We've had a number of fellows who went into practice and actually had to train the staff themselves how to do skin testing, because the people they hired didn't have any experience in doing skin testing. It's important that this is your specialty. You should know how to do the two things that separate us from other specialties: is skin testing and immunotherapy. So you need to be the world's experts on doing skin testing and immunotherapy, as far as I'm concerned. The proficiency skin testing, there's been a number that have been put out there of ways of doing it. John Oppenheimer and Hal Nelson, who was National Jewish, had a number of years ago put out a guidelines for doing proficiency testing, and I assume Dr. Miller and Dr. Algebron are still doing this at Children's Mercy, but as part of they're competent in doing skin testing, which is one of the procedures that you have to prove the fellows are competent in to graduate. They offer hands-on experience for the fellows, and I used to do workshops for the nurses as well. It's important, and again, that the fellows be proficient and can do these and have a good skill at this. So we used to do this on an annual basis, and there's some places that recommend even doing it more frequently for newer staff people and fellows. This is out of the guidelines from Hal Nelson and John Oppenheimer. And I won't go through all this, but you basically do skin tests and you measure the results, and then you calculate a variety of numbers, and you come up with the coefficient of variance, and you're looking for less than 30% variation between the size of your testing when you're testing for histamine and saline. And all your negative controls should be less than 3 millimeters of wheal and less than 10 millimeters of flare. So this is an example. You alternate the histamine and salines on the skin, and then after after the 15 minutes, you circle them with a magic marker, and then you apply tape to the top of those and lift that off, and then put it on a piece of paper, and then do your measurements from that. And this is an example when we were doing proficiency skin testing with the fellows at Children's Mercy, one of the fellows back. So the H is the histamine, S is the saline. So you can see the big reactions to the histamine and the no reactions to the saline. As part of the proficiency and the competency for procedures for skin testing, there's a checklist that Dr. Miller and Dr. Algeron asked the fellows, as well as doing the actual hands-on testing. And the importance of proficiency verification is to decrease the risk of false positive and false negative results, better diagnostic accuracy, avoidance of unnecessary therapies. So you don't want to put someone on allergen immunotherapy or food avoidance if they're really not allergic. Decreased failure to properly treat someone. Again, if someone's really allergic to a food or a drug, you want to know that and treat them appropriately. It decreases the cost of unnecessary testing and therapies. And again, more importantly, it's overall better and safer care and more effective care for our patients. So there's been some talk about how often you need to do the proficiency. Betty Liu, program director in Tennessee, had done a pilot study a few years ago where she took fellows and nurses and attending staff, and she had them do the same proficiency skin test that you saw, except instead of doing it on the back, they did it on the forearm. And they found, in her testing, they found that if you had greater than 4 years of practice in the clinic, or that you had less variation and more likely to pass. But as you see, only 7 of the 20 people that they did the proficiency testing on passed on the first attempt. It was concluded there was an inverse relationship of experience and the coefficient of variance regardless of operator, regardless of a physician or nurse. So the longer you've been doing it, the better chance that you had less variation of between your histamines. And so it's important to dedicate sufficient time to guarantee reproducibility, and that's important. And this is really important for nursing staff that get hired into the clinic, because if they don't have enough proper training, they're out there doing skin testing, and you're relying on the results of their skin tests to be accurate in making these important decisions. So it's very important that whoever is doing the skin testing has proficiency in doing it. And in this pilot study, they actually suggested having recertification, and depending on how quickly you became proficient and how long you've been doing it, they suggest maybe quarterly or twice a year or yearly, for especially those with less than 4 years of skin testing experience. So again, when I was at Children's Mercy, we had the fellows do this every year, and I used to have the nursing staff do it as well. So that's something to consider. And again, if you're going to be an allergist, you really should know how to do skin tests properly. So in summary, I've kind of gone through a whirlwind of skin testing here, and we still have a few minutes. Good. In summary, immediate skin tests confirm sensitization to an allergen. Immediate skin tests are simple, safe, reproducible, and sensitive. Interpretation of testing and identifying a true allergy relies on history. Again, you can't have an allergen without a true history of a reaction. Proper skin tests help in providing better diagnostic testing, safer care, and appropriate care to our patients. And the value of skin testing relies on proper technique and the person doing skin testing maintaining proficiency. There's my references. And Chris mentioned at the beginning that I split my time in Utah besides Las Vegas. We have a house up there. And a couple weeks ago, this was a picture I took of the sunrise after I fed the dogs early in the morning, and took this from our deck off the front of the house. So this was the start of a new day for me, and for the new fellows, this is the start of a new day for you. Your introduction to allergy with the summer series, and start of your new life as an allergist. And I welcome you to the allergy community. One other thing I'd like to tell the fellows, the new fellows and the existing fellows, is that if you haven't figured it out already, allergy is a very small world, and there's very few degrees of separation. If you are at Children's Mercy and you go into the conference room, you have on the wall pictures of the former fellows. Children's Mercy's had a fellowship since the early 50s, and the majority of those fellows that are graduated fellows that are on the wall are still allergists that are active in the communities that they live in across the country, and they are a great resource. And it's very important that as fellows that you network, because again, allergy is a small world, and it's amazing who knows who. And so I would encourage you to, when you go to the meetings, try to meet some of the former fellows from your own programs, and build up that allergy community for yourself. You'll be glad that you do. So with that, I'm going to end my talk with a few minutes to spare and take any questions if anybody has any.